I was standing in a hospital corridor at 11 p.m. when a family asked me a question I will never forget. Their father was 79 years old. He had just been wheeled into pre-op. The surgery was scheduled for 6 a.m., and his daughter looked at me with exhausted, terrified eyes and said, "Doctor, we already signed everything, but is this actually going to help him? Or are we just doing this because nobody gave us another choice?" I didn't have a clean answer for her that night, and that moment has haunted me ever since. My name is Dr. Walter Strong. I have spent more than 2 decades as a cardiothoracic surgeon. I have been inside more operating rooms than I can count. I have held beating hearts in my hands. I have watched surgeries succeed brilliantly, and I have watched them destroy the very lives they were meant to save. And what I am about to share with you today is something most surgeons will never say out loud, not because they don't know it, but because medicine has a culture of forward momentum. You come in with a problem. The system finds a solution. The solution is usually surgical. Papers get signed. The machine moves forward. What gets lost in that machine is the most important question of all. Is surgery actually the right choice for this specific person, at this specific age, with this specific body? That question can be the difference between a recovery and a tragedy. Today, I am going to walk you through 5 surgeries that carry serious, underreported risks for people over 60. I'm going to tell you what the statistics actually say, what alternatives exist that most patients are never offered, and exactly what questions to ask before you or someone you love signs anything. This is not a video about fear. Fear without direction is just paralysis. This is about information. Specific, honest, actionable information that every older adult in this country deserves to have before they ever step into a pre-op room. Stay with me through all 5, because the last one, the one most people think they have no control over, is the one where preparation matters most of all. Let's start with something fundamental that changes everything else. There is a difference between age and frailty. Most people confuse them, and that confusion costs lives. When I say a patient is 75 years old, I have told you almost nothing useful medically. I have told you a number. What actually predicts surgical risk is not the number of years someone has lived. It is the biological reserve that remains in their body, the capacity of their heart, lungs, kidneys, immune system, and brain to absorb the trauma of surgery and mount a recovery. That biological reserve is what physicians call frailty, and it is measurable. It is real. And it is far more common than most patients realize. Approximately 40% of adults over 75 show clinically meaningful signs of frailty. By age 85, that number climbs to nearly 60%. These are not people who look fragile necessarily. Some of them walk into my office and shake my hand with a firm grip and sharp eyes. Frailty is not always visible, but under the stress of a major operation, it becomes undeniable. Here is the clearest way I can describe it. Put a car with 30,000 miles through a stress test, and it performs predictably. Put a car with 230,000 miles through that same stress test, and the results are entirely different. Not because the car is worthless, but because its reserve is reduced. Every system is working closer to its limit. There is less margin for error. That is the older body under surgery. General anesthesia alone presents challenges that younger patients simply do not face at the same level. The heart works harder to maintain pressure. The lungs take longer to clear the anesthetic agents. The kidneys process medications more slowly, allowing toxic buildup. And the brain, and this is the part that consistently surprises families, the brain can become disoriented in ways that persist for weeks or months after the operation is over. There is a clinical term for this: postoperative cognitive dysfunction. In patients over 70, it occurs far more frequently than hospital discharge paperwork ever reflects. Patients come home confused. They repeat themselves. They become anxious or withdrawn. Families assume it is temporary. Sometimes it is. Sometimes it becomes permanent. None of this means surgery is wrong for older patients. I have operated on people in their 80s who recovered faster than patients 20 years younger. Age alone is not a disqualifier. But frailty changes the equation dramatically. And understanding that equation is exactly why we are here. So let us talk about the 5 surgeries where that equation is most critical. The first is open heart surgery in frail patients. Coronary artery bypass grafting, surgeons call it CABG, is one of the most commonly performed major surgeries in older adults. The logic is straightforward. Arteries become blocked. Blood flow to the heart is compromised. We reroute the circulation around the blockage using a vessel harvested from elsewhere in the body. In healthy, well-prepared patients, it is genuinely life-extending, and I am proud of every successful case I have been part of. But here is what the informed consent form rarely conveys in plain language. Open heart surgery requires stopping your heart completely. While the surgeon works, a bypass machine takes over the functions of both the heart and the lungs, mechanically circulating blood through the body. For a 62-year-old in strong cardiovascular health with well-controlled blood pressure and normal kidney function, that bypass machine is manageable. The body tolerates it. For a 79-year-old with early kidney disease, type 2 diabetes, mild cognitive impairment, and reduced lung capacity, that bypass machine is simultaneously stressing every major organ system in the body. The kidneys, already working at reduced efficiency, are now processing a flood of inflammatory mediators released by the bypass circuit. The brain, already operating with less reserve, is exposed to microemboli, tiny particles that can cause silent neurological damage. The lungs, already less elastic, must re-expand after being deliberately deflated during the procedure. Published research shows that in frail elderly patients, open-heart surgery carries a 30 to 40% risk of serious major complications. Stroke, acute kidney failure, prolonged mechanical ventilation, extended ICU stays, and months of profound cognitive confusion are all documented outcomes in this population. And in the highest-risk elderly patients, up to 15% do not survive the first 30 days following the operation. These are not rare edge cases. These are documented rates from peer-reviewed surgical literature. So what does the alternative look like? In a significant and growing number of cases, a procedure called TAVR, transcatheter aortic valve replacement, offers a catheter-based intervention that never requires stopping the heart or opening the chest. A cardiologist threads a catheter through a blood vessel, typically in the groin, and the new valve is delivered and deployed with the heart beating continuously. Recovery time is dramatically shorter. The physiological insult to the body is a fraction of open surgery. TAVR was once reserved only for patients too sick to survive traditional surgery. Today, evidence supports its use in intermediate-risk patients as well, and trials are ongoing for broader application. Does this mean you should refuse heart surgery if your cardiologist recommends it? Absolutely not. What it means is that you should ask one direct question before you agree to anything. Ask your surgeon whether you are a candidate for a catheter-based or minimally invasive approach. That single question, asked calmly and clearly, could redirect the entire conversation toward a safer path. The second surgery is aggressive spinal fusion in elderly patients. Back pain after 60 is so universal that it has almost become a cultural expectation. I do not know a single patient over 70 who has not mentioned their back at some point. And the surgical answer being offered to more and more of those patients is spinal fusion, sometimes involving multiple levels of the spine, extensive hardware, screws, rods, and permanent structural changes to how the vertebral column functions. Now, I want to be precise here because the nuance matters enormously. Some spinal surgery is not just beneficial. It is urgent and necessary. A spinal cord being actively compressed to the point of causing paralysis, loss of bladder control, or progressive neurological deficit requires prompt surgical intervention. I am not suggesting anyone in that situation delay care. That is a different clinical scenario entirely. What I'm talking about is elective spinal fusion for chronic degenerative back pain. Pain that has been present for months or years. Pain that is real and limiting and deserves serious treatment, but not necessarily surgical treatment. A major study published in the journal Spine examined outcomes in patients over 65 who underwent complex spinal fusion for degenerative conditions. The complication rate exceeded 40%. Not minor complications, significant ones. Deep wound infections requiring reoperation. Hardware failure. The screws and rods actually loosening or breaking under the stress of daily movement. Blood clots forming in the deep veins of the legs, capable of traveling to the lungs, and a particularly insidious long-term consequence called adjacent segment disease. When we fuse a section of the spine rigidly, the segments above and below that fusion are forced to absorb all the movement that the fused section no longer provides. Over time, that accelerated stress breaks those adjacent segments down, often requiring additional surgery, more hardware, and longer recovery. The operation designed to solve the problem can create a cascade of new ones. But here is the finding that I believe every patient considering spinal surgery deserves to hear clearly. For many elderly patients with degenerative spine disease, rigorous research shows that aggressive surgical fusion produces no superior long-term pain relief compared to structured physical therapy, anti-inflammatory management, and targeted epidural steroid injections. No better outcomes for pain, but dramatically higher risk. A colleague of mine with decades of spine surgery experience once told me something I have repeated to patients ever since. He said the most technically difficult thing a surgeon can learn is when not to operate. That wisdom took him 30 years to fully understand. I want you to have it right now before you ever need it. If you have been told spinal surgery is your only remaining option for back pain, I would encourage you to seek a second opinion from a physiatrist, a specialist in non-surgical physical medicine, before you agree to anything. The third surgery is major cancer resection in elderly, frail patients. This is the hardest category to discuss honestly, and I want to acknowledge that up front. When someone is diagnosed with cancer, the emotional urgency is immediate and overwhelming. The instinct to remove the threat, to cut it out, to eliminate it, is one of the most primal responses in human experience. I would feel exactly the same way if it were someone I loved. But 2 decades of surgery has taught me something that no medical textbook taught me cleanly. The goal of cancer treatment is not simply to remove the tumor. The goal is to give the patient more high-quality years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient achieves the first goal while failing the second one completely. Let me walk you through a specific example. The Whipple procedure is performed for pancreatic cancer affecting the head of the pancreas. It involves removing the head of the pancreas, a section of the small intestine, the gallbladder, and part of the bile duct. The surgery takes 6 to 10 hours. The recovery is prolonged and demanding. For a younger patient in good health, it can extend survival meaningfully and in some cases provides genuine cure. Now consider an 81-year-old patient, I will call him Raymond, who came to me with a pancreatic tumor and a history of congestive heart failure, stage 3 chronic kidney disease, and a body weight that had dropped 18 pounds in 4 months. His tumor was resectable on imaging. Technically, the surgery could be performed. 3 consultants had already discussed it as the primary plan. When I sat with Raymond and his daughter for nearly an hour, reviewing his frailty score, his cardiac reserve, his kidney function, and his nutritional status, the picture that emerged was not one that pointed toward surgery as the path most likely to extend his meaningful life. In patients like Raymond, the surgery may technically succeed. The tumor is removed, the margins are clean, the pathology report is favorable, and the patient still dies within weeks, not from the cancer, but from the operation. Post-surgical sepsis, multi-organ dysfunction, respiratory failure that a depleted body cannot reverse. This outcome has a name in surgical literature. It is called futile surgery, and a landmark analysis from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced what researchers call failure to rescue, a serious complication arising after surgery that the weakened body lacked the reserve to survive. 1 in 5. The conversation worth having and worth insisting upon is this. Ask your oncologist directly. If we do not operate, what does watchful waiting, radiation therapy, or targeted systemic therapy look like for someone with my age and health profile? What are the realistic survival projections for each path? Not for the average patient, but for a patient with my specific comorbidities. That question opens a door that too many patients never know exists. And sometimes the path behind that door, less dramatic, less surgical, less frightening, provides more good months of life than the operating table ever could. The 4th surgery is elective joint replacement in severely medically compromised patients. Hip and knee replacement surgeries are, for the right patient, among the most genuinely transformative procedures in modern medicine. I say that without reservation or qualification. A well-timed, well-executed hip replacement can return a person to activities they had abandoned for years. I have seen patients go from struggling to cross a parking lot to walking their grandchildren to school. The outcomes, when patient selection is appropriate, are remarkable. But the word elective carries enormous weight that most patients underestimate. Elective means this surgery is planned. It is not an emergency. No one is in acute danger if the operation does not happen today or this month or even this year. That planning window is not an inconvenience. It is an opportunity. An opportunity to ask whether this is genuinely the right moment for your specific body, with its specific conditions, at its specific level of readiness. Because here is what the data shows for patients over 75 who carry 3 or more serious medical conditions simultaneously: heart disease, poorly controlled diabetes, chronic kidney disease, class 3 obesity. Elective joint replacement carries substantially elevated risk of perioperative complications that go well beyond the expected post-surgical soreness. Deep vein thrombosis is the most serious concern. Blood clots forming in the deep veins of the legs after joint replacement are common. In younger patients with healthy circulation, these clots are caught and managed before they become dangerous. In elderly patients with already compromised venous return, these clots can travel to the lungs, a pulmonary embolism, with potentially fatal consequences. Blood thinners are used routinely to reduce this risk, but blood thinners in frail elderly patients with kidney disease or gastrointestinal vulnerability carry their own serious risks. Add post-operative pneumonia, which develops when patients remain immobile longer than expected. Add hospital-acquired infections, particularly dangerous for patients on immunosuppressive medications for autoimmune conditions. Add the anesthetic complications we discussed earlier that affect the aging brain. The picture becomes far more complex than the procedure's reputation for success suggests. Here is what I tell every older patient considering joint replacement when their medical profile gives me pause. The surgery is not off the table, but the table needs to be set correctly before we sit down to it. Optimizing your cardiovascular health before elective surgery can reduce complication risk significantly. Bringing blood sugar under tighter control in the weeks before the operation reduces infection rates meaningfully. Supervised pre-surgical physical therapy, a formal process increasingly called prehabilitation, strengthens the muscles around the joint and improves respiratory capacity so that recovery is faster and safer. Some of the most progressive orthopedic programs in the country now require a formal prehabilitation protocol before they will schedule joint replacement in high-risk elderly patients. This is not a delay tactic. It is evidence-based preparation that changes outcomes. Ask your orthopedic surgeon this question. Before we schedule the surgery, what optimization program would you recommend to give my body the best possible chance of a smooth recovery? If your surgeon has no meaningful answer to that question, that itself tells you something important about their approach to your care. The 5th surgery is emergency abdominal surgery in elderly patients. Now I need to pause and acknowledge something important before we go further. This surgery is different from the other 4 in one crucial way. You do not choose it. It chooses you. A perforated bowel, a ruptured abdominal aortic aneurysm, a bowel obstruction with compromised blood supply. These situations do not allow for calm deliberation in an office. They arrive at 2 a.m. with severe pain and they demand an answer immediately. So why does it belong on this list? Because knowing the risks before the emergency happens changes how families respond in the moments when response matters most. And because there are concrete steps that reduce the likelihood of ever facing this scenario as an emergency rather than a managed, planned intervention. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgical medicine. Depending on the specific condition and the patient's baseline health, 30-day mortality ranges from 30 to 50% in the most severe presentations. Not because the surgeons performing these operations are unskilled. The technical capability in our trauma and emergency surgical teams is extraordinary. But because an elderly body sustaining sudden severe physiological trauma is fighting an overwhelming number of battles simultaneously, the liver is flooded with bacterial toxins from a perforated bowel. The kidneys, already functioning at reduced capacity, are suddenly asked to clear an enormous inflammatory load while blood pressure is dropping. The heart, perhaps already working with reduced ejection fraction, is asked to maintain circulation through shock And the immune system, which in a younger patient would mount a fierce and controlled response, triggers in an older body an unchecked inflammatory cascade called systemic inflammatory response syndrome, SIRS, that can cascade into multi-organ failure before the surgical team has finished closing the incision. This is not a theoretical risk. It is a documented pattern that emergency surgeons navigate every single week in hospitals across the country. So what can you actually do with this information? Two things, and both of them matter enormously. First, do not ignore abdominal symptoms in yourself or in elderly family members. Persistent abdominal pain that is new or changing, unexplained bloating that does not resolve, significant changes in bowel habits, blood in the stool. These are not symptoms to watch casually for a few more weeks. In a person over 60, these symptoms warrant prompt evaluation. Catching an abdominal aortic aneurysm when it is still small allows for an elective planned repair, a far safer procedure than emergency surgery on a rupture. Catching diverticular disease before it perforates allows for dietary management or elective surgical repair under controlled conditions. Early detection does not just improve outcomes. In many cases, it completely changes the category of intervention required. Second, have the conversation with your family now. Not in a hospital corridor at midnight when someone is being rushed into pre-op and fear is making every decision for you. Now. What are your wishes if emergency surgery is the only option being offered? What quality of life matters to you after the operation? What would you want if the surgical team told you the procedure carried a 40% chance of not surviving the first month? These conversations are not morbid. They are not pessimistic. They are one of the most loving and responsible acts you can perform for the people who will one day stand in that corridor on your behalf. Advance directives, healthcare proxies, honest family discussions about goals of care. These documents and conversations become the voice you cannot use when you are unconscious on a gurney. Please have them. Please have them while there is time and space to do it thoughtfully. Now let us bring everything together into something you can actually use. Before any major surgery, planned or recommended, every patient over 60 should ask 4 specific questions. These are not adversarial questions. They are not accusations. They are the questions of an informed, engaged patient who is taking their own care seriously. Write them down. Question 1. What happens to my health if I do not have this surgery? And what does that trajectory look like over the next 6 to 12 months? A skilled, honest surgeon will give you a direct answer to this question. If the answer is that nothing acutely dangerous will happen in the next several months, you have time. Time to think carefully. Time to get a second opinion. Time to optimize your health before making a decision. If a surgeon becomes dismissive or impatient with this question, that response is itself information worth having about whether this is the right surgeon for your care. Question 2. Is there a less invasive alternative to open surgery that might achieve a comparable result for my specific condition? Medicine has changed dramatically in the past 15 years. Catheter-based cardiac interventions, laparoscopic and robotic abdominal surgery, endoscopic spinal procedures, ultrasound-guided joint injections. Options that did not exist a decade ago are now available at most major medical centers. Your surgeon should be able to tell you clearly whether these alternatives apply to your case and why or why not. Question 3. What does recovery realistically look like for a patient with my exact health profile? Not the average surgical patient, but someone with my heart function, my kidney numbers, my current medications, and my living situation. The answer to this question should be specific. If you live alone, if you have no caregiver at home, if your nearest family member is 3 hours away, those facts should be part of the surgical conversation. Recovery does not happen in the hospital. It happens at home, and the conditions at home matter profoundly for outcomes. Question 4. What is your personal complication rate for this specific procedure in patients over 70? Surgeons track this. They know their numbers. High-volume, experienced surgeons at major academic centers have measurably different complication rates than lower-volume surgeons at smaller facilities for complex operations. A confident, transparent surgeon will tell you their numbers directly. If a surgeon seems uncomfortable with this question or deflects without providing specific information, that discomfort is itself data. Now let me tell you about a patient. I am going to call him Thomas Hartwell. Thomas was 73 years old when he came to me. A retired civil engineer from outside of Denver, Colorado, precise thinker, careful with his words, brought a yellow legal pad with written questions to our first appointment. 3 different cardiologists had recommended open-heart bypass surgery for a significant coronary artery blockage. 3 separate opinions. The same recommendation each time. Thomas was not opposed to surgery on principle. He was not a difficult patient. He was a man who had watched his older brother go through open-heart surgery at 71 and return from the experience profoundly changed, more forgetful, more fatigued, less himself, in ways that never fully reversed in the 2 years before his brother passed from an unrelated cause. Thomas told me, quietly and without drama, "Dr. Strong, I don't want to survive the surgery and lose the person I am. That's not a trade I'm willing to make without understanding every option." So we took the time. I reviewed his complete profile, his kidney function, his frailty assessment, his baseline cognitive testing, his home environment, his goals for his remaining years. We discussed his case at our multidisciplinary cardiac conference, and what emerged from that thorough review was that Thomas was a strong candidate for an aggressive, optimized medical management protocol combined with cardiac rehabilitation, a supervised, structured program of monitored exercise and lifestyle modification with close pharmacological management. The published evidence for patients with his specific profile showed comparable 5-year survival outcomes between that approach and surgical intervention. Not inferior outcomes, comparable ones, with dramatically lower risk in the short-term recovery window. Thomas chose the non-surgical path. Last spring, almost 4 years after that conversation, his daughter sent me a photograph. Thomas is standing at the trailhead of a hiking path in Rocky Mountain National Park. He has a walking pole in each hand and a grin that takes up most of his face. His 2 teenage grandchildren are standing beside him, and both of them are taller than him now, and all 3 of them look like they are having the best possible day. I have that photograph saved. It reminds me why the conversation matters as much as the operation. Here is what I need you to understand above everything else I have said today. A surgical recommendation is not a verdict. It is a starting point. It is one expert's assessment of one possible path forward, and it deserves to be heard, respected, and then thoroughly questioned. You are not a passive recipient of medical decisions. You are an active participant in the management of your own health. You have the right to ask every difficult question. You have the right to request every alternative. You have the right to a second opinion, a third opinion, as many opinions as you need to feel genuinely informed. And you have the right to take whatever time exists to make a decision you can live with, literally. The surgeon holds the scalpel. You hold the choice. Let us bring all 5 together one final time. Open heart surgery in frail elderly patients, where catheter-based alternatives now offer comparable results with a fraction of the physiological cost. Aggressive spinal fusion for chronic back pain, where rigorous evidence consistently fails to show superior long-term pain relief over non-surgical management in older patients. Major cancer resections in severely compromised elderly patients, where the goal must always be more good quality life, not simply a technically successful tumor removal. Elective joint replacement in patients with multiple serious medical conditions, where timing, preparation, and prehabilitation can be as important as the surgery itself. And emergency abdominal surgery, where the most powerful tool available is catching problems early and having honest family conversations before the emergency ever arrives. None of this is a case against surgery. Surgery is one of the most powerful healing tools medicine has ever produced, and I have devoted my career to practicing it with everything I have. What this is a case for is informed consent that is genuinely informative. Surgical conversations that treat patients as intelligent adults capable of weighing real trade-offs. A medical culture that slows down long enough to ask not just can we operate, but should we operate on this person at this moment? You deserve a surgeon who takes time to explain everything clearly. You deserve a medical team that sees your age, your health history, your life, and your goals as relevant factors in every recommendation they make. And you deserve to walk into any surgical decision with your eyes fully open. Your age is not a weakness. Your questions are not obstacles. Your desire to understand what is happening to your body is not an inconvenience. It is exactly what good medicine requires of you. What is the one question you most wish you had asked, or could ask, before a major medical decision? Share it. Your experience might be exactly what someone else in this community needs to read today. Take care of yourselves. Stay curious. Keep advocating. You have earned that right, and your health is worth every question. Everything shared in this presentation is general medical information drawn from published clinical research and professional experience. Every individual situation is unique and complex. Before making any decision about surgery or treatment, please have a thorough and honest conversation with your own physician or specialist who knows your complete medical history. That conversation, direct, informed, and unhurried, is where excellent medical care always begins.